evening, everybody. I hope I'm audible to everybody.
Yes. Please go ahead.
Can you see
You have
myself?
9 minutes. Yeah.
Yeah. So, good evening, everybody. I hope everybody is doing well in these tough times. Thank you, Yossi, for this opportunity, and thank you, Dr. Apurva, for this introduction. So, I'm going to talk about TORIC IOLs, top pointers for incorporating in your early practice. So we know use of toric IOLs in cataract refractive surgery is already well documented today and often comes with little hesitancy on when and how and in whom to start this procedure. But for all young ophthalmologists, especially when we get into that sweet spot in that few years after we start our practice, when we reach a comfort zone with our monofocals and their surgical outcomes. I hope this talk helps everyone to take the next possible step in the right direction of choosing toric IOLs. So start early, start strong. It avoids that mental block that I was talking about. And remember, toric IOLs is 99% planning for success and 1% dealing for failure. And when it's a failure, it's not too catastrophic. So the armamentarium we require to start toric IOLs early includes correct patient selection and optimizing our biometry, the IOL calculations about getting them right, and the perioperative nuances and post-operative troubleshooting, which I may hint about if time permits. So you also need some bank balance because you need all the latest machines to get your calculations just right. So my weapon of choice in my practice is the optical biometer from TOMI, which is OA 2000D, which essentially uses the swept source technology. So it's pretty accurate with its findings and often also helps through dense cataracts. And also has a very good anterior corneal topographer with reliable readings. Other than this, other biometers like IOL Master 700, also swept source, and a lot of great topographers are also there. But if you have a good A-scan, use the immersion and a very good topographer, along with that, that's also a very good combination to go ahead with. My second weapon of choice is absolutely free of cost. It's the Barrett Toric calculator. It's available online for free at APACRS or ASCRS website. Very easy to use. I can share a few things about how to calculate and make it easy also. We also have the TrueCade Toric calculator available now. So special note, often people say I only use torics for large astigmatic corrections. My take, start with smaller astigmatic correction like 0.751, often known as the T2s. Because they often come in that little sweet spot where the patients are more forgiving if it turns out to be misaligned. So ideal for beginners. So result of using torics in my practice is that my attitude towards cataract surgery has changed. Every patient has now become a candidate for astigmatic reduction. I put most of my patients through this calculators to find out if toric is required, even for the smallest ones. And the aim is to get good quality post-op uncorrected vision. Goal is to reduce dependency on glasses, and I've become a refractive cataract surgeon. And even before I do vision, I now check for astigmatism. So top tip number 2, who do we select? So the main culprits when toric IOLs are needed, in the case of corneal regular astigmatism with significant with the rule or even minimal against the rule astigmatism with no other corneal abnormalities. When we talk about against the rule, we know the patients don't tolerate against the rule astigmatism as well as they do with the rule astigmatism. So go easy on with the rule astigmatism. This is owing to the posterior corneal astigmatism, which we often don't calculate or notice in our topographers because mostly we have anterior corneal topographers. This posterior corneal astigmatism itself is said to be against the rule and negates when we talk about leaving the patients with the rule, thereby minimizing the total astigmatism. So the patient should have some desire to improve the distance vision with less dependence on glasses. A little bit more who not to. Somebody who's had previous refractive surgery may not be the best ideal person for a beginner, has previous corneal surgery, has pre-existing other ocular pathology, does not have an intact capsular bag or loose zone use, even in pseudo exfoliation, because a beginner may be a little more difficult for them to dial in these cases. Top 3, chair time with these patients. Give chair time with them, speak to them, explain astigmatism with simple day-to-day examples, discuss spectacle independence, excellent, talk about distance vision being excellent, balance their expectations because often there can be a rotation. They will still need readers when you're not putting a multifocal, and then make a recommendation. Do speak about less dependency. Do not guarantee that. Be cautious. handling high expectations, and especially those perfectionist patients that you may have come across. Mention about alignment and special IOLs. Address the possibility of realigning or repositioning postoperatively if need be, and address the cost difference. Don't settle, because if you're comfortable with a particular toric IOL, which may be a little more expensive, don't settle and go for something else that you're not comfortable with. Top tip number 4, people fail, checklists don't. Now, this is very, very important, because have a particular checklist ready, because you have to go through the drill. Every patient should go through the same drill, so that you get your calculations bang on. This includes a dry eye analysis, includes getting the OCT done for the macula, because you don't want to put something in the case where the patient may not have good vision. And also your Barrett calculations. Perioperative checklists include ordering of the IOLs. Now, do the ordering yourself if possible, when you're free, not when you're in between OPD, because mistakes in your calculation will lead to mistakes later on. And it should be ordered with the particular cylindrical number. Don't use T2, T3, T4, because every company does not follow the same. And checklists for receiving. When you receive them, there should be a checklist on recalculating or rechecking or making sure that you've got the right IOL. Checklists for pre-op mentioning in your OT list, the IOL and power with the cell, not just the label. And checklist for toric sheet in the OT, because you need to have your toric sheet ready when you operate. Top tip number 5 is precision in scans. Do it yourself. If you can, do your own scans. Avoid any guesswork of how it would have been, how the Myers were. Don't do that. Do it yourself so you're clear about it. Do repeat your investigations on different dates or different times if necessary or if possible. And always on the same machine as much as possible. Avoid dilated scans. Treat dry eye tear film instability before planning any toric IOL implant. Barrett suite is free, available online. Always run them through that. Don't rely on the machine inbuilt calculations, because because the online version is always updated, and that may be the right one to go for. Topography is key. Corneal topography is the key. These are a few examples of good candidates where there's regular astigmatism. Warning signs when there's irregular astigmatism or asymmetric astigmatism. A quick tip on this is that if the pupil is small in scotopic and photopic, you can make a small circle and find out how the patient will do if you put a toric IOL. And that should be only done after counseling the patient if there's a risk. Top tip number 6, choose your lens wisely. Always scan both the eyes together, because you may have a monofocal in this particular eye and you tell them this is your lens. And when the other eye comes, suddenly the price has gone up. They may feel cheated. So always tell them beforehand that toric may be required in your other eye if required. This helps in counseling them long term and reduces refractive surprises later. Special note, go easy on correcting with the rule, more aggressive on against the rule. If you have a topographer which estimates posterior corneal astigmatism, you can use this finding for better results in the Barrett TrueK. Otherwise, don't worry. The Barrett and nomogram has adjusted posterior corneal astigmatism, which often gives very good results, and studies have shown it's as good, slightly not as much.
The average stroke risk above 9%, not much of increase with anti-VEGF therapy if you are careful. So that brings into the point how I'm going to be careful. How do I choose?
Lalit, I think you are on another webinar.
Outpatient and price.
Okay, so repetitions and repetitions. So this is a repeat slide that put Jan Bujke so that we repeat our calculations. Remember to keep your OT list ready. Keep checking your IOLs, because a mistake here will be mistake later. So rotations and IOL designs, another study where they compared a lot of IOLs from Acrosoft and the Technis version, no financial interest here. But they said that Acrosoft was tend to rotate less as compared to—
So 1 minute remaining.
Okay, so I'll rush through my slides then. So these are various IOLs available in the market. Find out what is your favorite and go ahead with that. Choose what suits in your hand. Don't settle with the patient. Anticipate rotation and with design and experience. Multifocals and EDOFs, consider for even minimal astigmatism. The 7th tip I would give is the SIA to the rescue. SIA calculators are available. And if you know your SIA, you can use the incision size and your SIA to minimize or maximize or whatever suits the patient the best and get the best outcome. Number 8, don't forget about the dry eye. Tear film, don't underestimate it. Dry eyes can make your readings faulty. It can lead to suboptimal vision after you correct the IOL, even when you achieve the right alignment. So take time, look for dry eyes, treat that, and then plan your surgery. Check your mark. Use your preferred way of marking. Check it under a slit lamp, deepen the mark, and all this before dilating the eye. I like to use the toric marker, which is the bubble marker. And I also like to check my patient from the TORICAM app after I do that. Intraoperatively, mark your...
And we know everybody except, yeah.
Okay. So intraoperatively mark before you start so that you know where you have to place your IOL in the end. A few more intraoperative tips: make your incision size. If you can get away with a larger size and that reduces astigmatism, always helps. Otherwise, place the IOL in the bag, and after you place it with an adequate viscoelastic, place it 10 degrees or 15 degrees off your final mark. And when you go ahead and you finally do your IA, under hydro, you can place it 5 degrees or on the mark, depending on how you like it. It is recommended that you can leave about 5 degrees for anticipated clockwise rotation. So post-op troubleshooting guides, do I have time? I can go through this, or I can skip it.
I think we'll stop here, Dr. Aditya.
Sure.
That was an excellent talk. I wish we had more time.
Yeah.
I wish we had more time for discussion. That was one of the best talks of the session. Congratulations.